Hello, guys. I think you are live now. Let me share. Let me check. Uh, yes, can you see me in the? Please tell me if you are not live yet. Not live. Yes, now
Hello?
you are live. Uh, it's a pleasure to receive today Dr. Agustin Cajon from Paraguay to talk about this severe IOL tilt in Yamani technique. And after this special talk, you have our two fellows, Dr. Mohammed and Dr. Ikmal, to discuss. Agustin, it's a pleasure to have you here. Thank you, my friend.
Hi, good morning, everybody. First, I just want to thank you for the invitation, and I want to share with you this case. So I'm gonna run the video right now.
Yeah, it's a pleasure. You can start one to one when you want.
Okay, but I cannot run the video here. It's here, but can you
Yes,
allow me
if you
this
want,
right
you
now?
can run the video.
Oh, the video is here. Share screen.
Checking the video. Yes.
Yes. Okay. So this is a case, a very rare case for me, at least. This is a 50-year-old male with blunt trauma. So I will try to save the back in this case. After the phaco, I noticed that the sonar weakness are very intense. So I decided to perform vitrectomy and scleral fixation technique, in this case with the Yamani technique. As you noticed, the technique was not so traumatic and went very smooth. Not too much manipulation was carried out in this case. The first haptic goes well. The second haptic, I like to perform the handshake approach. It's easier for me to dock the second haptic during this maneuver. So as you see, the case went very smooth. Just the main problem was the pupil, small pupil during the fixation. But at the end of the surgery, I know the IOL was centered. As you see, the haptics was symmetric. The IOL was centered and no tilt at the end of the surgery. At the first post-operative day, the fellow talked to me with a message, sent me a message, and he said that the IOL was a little bit tilt. At that time, I was not on the hospital, so I told him that I will see the patient on Thursday. I don't have the slit lamp picture, but on Thursday I saw the patient, and the IOL was, like he said, a little bit tilt. So at that time, I was unaware of this complication. That was on 2021. So uh, I don't know what happened. So I decided just to perform an IOL exchange. I thought that was a problem with my technique. You see that the haptic is very firmly attached. The other haptic is not too tight, so I decide to pull it from the sclera. But I think that that's not the best maneuver. So you see that a little bit of UVL tissue keep in the tip of the haptic. So for the other haptic, I decide to dissect the sclera, cut the bulb, and disinsert. Then I cut the IOL just as regular with the Pac-Man technique, and perform another Yamani a little bit decenter from the original one, as you see. Not in the same tunnels. The IOL was centered, as you see. The post-operative went well, and at 1 month, the visual acuity was good. So, what is this complication and why does it happen? In the last year, there was a more publication about this, and you see this video on YouTube, like it's a free optic haptic rotation. The optic rotate free in the junction, so no stability. That's why the phenomenon called rotisserie in this attic. And in this case, the other attic was the attachment was well, so no rotation noted. How can we manage this case otherwise than exchange? There is a publication to conservative management, so I will share the video.
There's nearly 90 degrees of tilt
You see
to the
the
optic.
same picture, the severe tilt, and in this case, the authors rotate
To correct the tilt, we
the optic.
orient the optic parallel to iris plane with the help of a Coughlin hook for support. Then endo laser is set at 250 milliwatts on continuous treatment, and that's applied to the optic haptic junction. You can see slight bubbling and whitening of the haptic where it inserts into the optic. This cures and sets the optic in the desired orientation. When the Coughlin hook is removed, we see that the optic remains in a very stable and flat orientation on its own without any support. Similar treatment is then applied to the nasal haptic. Here's the lens orientation at the end of the case compared to its appearance at the beginning.
So the how this works, the authors apply laser to the haptic optic junction. So the energy was applied there, and the haptic expands, so create a more secure attachment in that junction. So the conclusion here and the publications tell us that this complication is more frequent with the CT Lucia IOL by far, but there is also a reported with other models of IOL, so could happen with any IOL. The haptic optic junction distortion can occur early in the postoperative period, or even in that case is intraoperative. Just a few minutes after the implantation, the optic tilts severe. So it's not always related to the technique. The risk factor are small pupil, excessive manipulation, and hypotony in the postoperative period. So that's all, and thanks, Sergio, for the invitation. I hope that this case was a good case for you. Thank you.
Agustin, yes, it was amazing. Last week we discussed about this laser lock technique, and was perfect that you present for us today, because the fellows can close the thinking how it can happen. That video that you show, I don't know if you can back in this video how the IOL rotate in the haptic. Can you back in that video? Not this one, but the other video that the
Yes, yes.
surgeon show how the, yes, this one. So guys, really important. So is how there is this observe. So we discuss it a lot of times, because sometimes the IOL stay flat in the intraoperative, but as Agustin showed us in the day one month after, there is the rotation. So it can happen, and this laser lock technique is a good option if you use Yaman technique. Agustin, anything else that you want to add in about this case? I really like. I told you in Faco Extrema when your fellow
Yeah,
tell Agustin, prof, a little tilt. Yes, really, it's because your fellow respect you. A little tilt.
yeah. He was a other uh, concept with the tilt problem. Yes, the thing, the case was just I present the at the end of the surgery, the IOL was very good. At the first postoperative, the IOL was so tilt. Like I said, I was unaware of this complication at that time. The publications are mostly from 2023 uh, to now. But I think the laser lock is a good option. I didn't perform yet, but some authors claim that is the phenomenon can return. So you must decide what you do, because the patient can be like three surgeries for one problem because the problem was not solved. So it's a very hard decision. Some surgeons claim that they no longer use the CT Lucia, so they change for another platform with less incidence with this phenomenon. So uh, it's something you need to think what you're gonna do.
Agustin, thank you for your presentation. If you have time, you can watch Dr. Fihan to
Yes,
discuss
yes.
now about the because this week is the week 8 in the advanced cataract course, and you are discussing about subluxation IOLs, and I select the paper about the double-flanged, the first paper that discussed the technique. Mohamed, are you ready?
Yes, I'm ready.
Let's go.
Yes. Is my screen is fully displayed, Dr. Sergio?
Perfect, perfect.
Yes. I'd like to welcome you, everybody. I'm Dr. Mohammed Finjan from Iraq, Baghdad, and welcome in our weekly meeting of Canabrava's fellowship. My talk will be about the double flange technique in cases of ectopia lentis. Here is the first article by Dr. Sergio and his colleagues for three cases, two of Marfan syndrome and one of microspherophakia. They developed a new technique for managing these cases with preserving the capsular bag for IOL insertion. So as we know, ectopia lentis, which is the displacement of the crystalline lens within the pupillary plane, and it may be autosomal dominant or associated with the well-known syndromes, Marfan syndrome, Marchesani, and homocystinuria, which account for around 75% of non-traumatic cases. As we know, there is zonular weakness and intraoperative challenges in these cases. Historically, a variety of methods have been and devices have been developed for these cases, starting from the standard conventional CTR when the zonular weakness is less than 4 quarter clock hours, passing to the modified CTR with the sioneering single or double eyelids, and to the capsular tension segment, those for more progressive weakness or more extensive weakness. These two devices or three devices permits the intra-capsular bag IOL insertion, and also there is other method of IOL fixation, for example, scleral fixations. And on the other hand, all of us know that there is a complication, late or long-term complication associated with the sutured technique. For example, if we use the 10O suture, which associated with late degradation and pseudophacogenesis. In this novel technique, the materials needed is the 5-O-proline suture, portable cautery, and CTR, CTS, along with the microforceps, 23-gauge microforceps and 26-gauge needle. Here I'm trying to highlight the difference between, we have two CTS segments, Ahmed segment and the Canabrava flanged or angled, we can say angled segment. The Ahmed capsular tension segment is a flat one that may be associated with the tilt, while this angle is better to manage post-op tilt. So the surgical technique starts by creation of CCC with the femtosecond. Femtosecond is the best in these cases, and then insertion of CTR, standard CTR plus minus capsular hooks to distribute the capsular bag and decrease the flacidity of the posterior capsule. In this technique, they recommend that the nucleus should be hydroprolapsed into anterior chamber to avoid further stress on the weakness, followed by phacoemulsification above the iris plane. This photo showing us the CCC created by femtosecond. This is the from on the left from the femtosecond catalyst report, and B photo shows the intraoperative of femtosecond CCC. Then after that, we start to create the sclerotomy 2 millimeter behind or opposite to the quadrant of the zonular weakness with the 26-gauge needle. And we should keep attention that the needle enters the anterior chamber between the anterior capsule and the posterior iris plane. Then, with the aid of the microforceps, we thread the 5O polypropylene suture into the needle's cavity. And then the needle used as a guide to externalize the suture through the sclera. We will see this in these photos, on these diagrams. In A, we are seeing with the aid of the microforceps, this suture is threaded into the lumen of the 26-gauge needle, and then in B, it is externalized, B and C externalized throughout the sclera. After that, we go to the corneal side of the suture, passing it through the suturing eyelet of the CTS and then making the first flange. Now we have a complex, the CTS 5O micro monofilament complex that is inserted intraocularly in the same quadrant of the weakness. Finally, the external side is cut at approximately 2 millimeter, and then creation of the second flange. So, and finally, the second flange is inserted into the scleral tunnel using the McPherson technique. There is a video at the end of my talk. This is the subsequent steps. Now, in D, we see that the other end, which is outside the eye, at the corneal incision side, we passed through the eyelid of the CTS and then heated and creating the first flange. And then the other end, the scleral end, it is cut at 2 millimeter and then making the second flange. And this is the final double flange after insertion of the second flange into the sclera and implantation of the IOL. Again, this is the intraoperative steps, same steps, this insertion, threading the suture, and then making the first flange in C, and now insertion the CTS 5O segment into the eye, and then making the second flange, and finally IOL implantation. Attention should be kept here that the first flange, yes, should be on top of the CTS segment, as shown in the picture or photo to the intraoperative photo to the left, while in the picture to the right, we see that this is the wrong way of making the first flange, which is just beneath the eyelid. It should be on top, not underneath it. I'd like to focus here on the microspherophakia case. In this article, there was one case of microspherophakia, and as we are seeing now, there is the diameter is just about 7.8 millimeter, and in these cases, we should use double or two capsular tension segments. This is a post-operative on the right, the post-operative photo showing the two eyelids of two CTS segments. And here it is a good opportunity to highlight in that the sizing of the capsular tension ring in cases of microspherophakia. As we know, there is 3 conventional sizes for the conventional CTR. This is the first size, which is 12 millimeter outside the eye and 10 inside the eye. This is the let me say regular size. While for microspherophakia, we should use a smaller one, which is 10.8 millimeter for capsular tension ring in cases of microspherophakia, as Dr. Sergio keep telling us this. In conclusion, this novel technique is good for stabilizing the capsular bag in cases with ectopia lentis using the CTS 5O proline complex. It is faster to perform and use less ocular trauma with the absence of tight sutures, flaps, or glue. There is less technical difficulty than previously prescribed techniques, and minimize the transitional complication associated with the traditional technique and late suture degradation with subsequent IOL subluxation. So IOL centration and bag stability outcome are similar to those achieved with conventional suture-held CTS. However, long-term stability of thermally created flanges have not been confirmed yet, and as a new technique, further studies with more patients and longer follow-up is recommended. What was known before this article, that cataract surgery, patients with Marfan syndrome and or with the zonular weakness of dialysis may be problematic, and these problems are currently managed by anterior chamber IOLs, iris fixed posterior chamber IOLs, scleral fixed IOLs, or IOL placed in the capsular bag with a capsular tension ring or segment, and suture to the sclera with the polypropylene or with Gore-Tex sutures. What this paper adds that the double-flanged transscleral bag fixation technique is a new, not free option for managing patients with Marfan syndrome with zonular weakness or dialysis in eye undergoing cataract surgery. And this new technique provides a new, less expensive, faster, and easier way to treat subluxated cataracts. Now we will be with the video. As we see, after the creation of the CCC with the femtosecond, now the surgeon trying to insert the CTR after putting viscoelastic. He's inserting the CTR, standard CTR, into the capsular bag to stabilize the bag and to distribute forces. He's using Sinsky when the method of inserting CTR is with Sinsky or with microforceps. And after that, trial of nucleus hydroprolapse with phacoemulsification above the iris plane. Now, starting by passing the 26 gauge needle 2 millimeter opposite to the quadrant of the subluxation. As we said, it should be between the anterior to the capsule and posterior to the iris plane, and threading the monofilament suture polypropylene in it. Make as a guide, the needle will externalize the suture and make it out. Now, passing the suture through the eyelet, and as we said, it should be on top of the CTS. Now, testing it by pulling it, the polypropylene complex into the eye, with the other arm taking the suture from the scleral, balancing it to make it incise the bag with the distribution of the forces. Cutting it 2 millimeter and making the second flange. And lastly, inserting it with McPherson into the sclera with the IOL implantation. Here they prefer the 3-piece IOL. And this is finally the case. Post-op view of the patient. And thank you.
Mohammed, good presentation. Special points in this technique is create a long scleral tunnel, because it's important to bury the flange inside the sclera. It's a really important point. Another point, I prefer to insert the CTR before to the phacoemulsification. I believe in my case, if you can unshare your screen, Mohammed, I think your screen is shared. Okay. I believe when you insert the CTR before, you have more stability, okay? Especially when you remove the cortex, because the CTR holds the bag for you. Another important point is hold the polypropylene, pull it, okay? Pull it and hold in the base, because you need to create some tension. It's like when you do a knot, and of course, bury the flange inside the sclera, okay? Another point is, when I start to perform phantom second laser in my subluxation cataract case, it's increased, is better my number of good results, okay? Less necessity of vitrectomy, posterior vitrectomy, because the phantom do the rex for me. And when you perform the rexes, sometimes you produce traction in the zonal. Mohammed, any comment or question that you want to do about this paper, this double-flanged technique?
That's clear, I think.
Do you want, Agustin?
Yes, where we can get your CTS, for these cases? What?
Yes, the anglet CTS you can't it's produced by Madu Instruments, and it's an anglet. And the idea of this CTS was to reduce the tilt when you pull the flange, and till now you have good result. Dr. Mike Snyder from USA is testing it too. Yes. because it's good to another surgeon test is to avoid vias and bias. And so, but till now, good results introduced by Madhu Instruments from India.
Okay, thank you.
Can you see me?
Yes.
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 Okay, Agustin, another question.
And what diameter you use in the
Diameter.
in the rexis for in this case
In the Rex,
10%.
about 4.8 million, 4.8, but
Okay.
depends on how subluxate is the IOL, how subluxate is the lens. Because a large subluxation is difficult to perform the phantom laser. Okay, so sometimes you did do less than 4.8, 4.4, 4.2. I know it's difficult, but this patient with Marfan syndrome is normally a young patient, 25, 30 years old, and this capsule is more flexible. So if you do a small capsule, you can enlarge it with the iris retractor or iris capsule rooks. And but it's important to pay attention in the post-operative because sometimes you can have a contraction syndrome and you need to do a eye laser to avoid the contraction syndrome.
Okay. Thank you, Sergio.
So Ikmal, are you ready?
Yes, I'm ready. I'll present my screen.
Ikmal, introduce yourself for everybody here.
All right, all right. I put my slides first. All right, from my computer. All right.
Yes, you can share your full screen. And so,
Wait, I just.
you go in share screen or
Okay, all
presentation.
right. Could you see my
Yes,
presentation? Okay, okay.
yes,
My name
yes.
is Dr. Ikma Kamil
But
from.
Ikmal is
Yep,
not in full screen.
in full screen.
Click in the full screen. Yes.
All right. Is it okay now?
No, no. I think it's because you share your window. You need to share your full screen. Enter
Okay.
screen
Okay. Uh,
and share, and you need to share your full screen.
Share full screen. Yes. Is it okay now?
Yes, perfect.
All right. Okay. I am Dr. Muhammad Ikmal Muhammad Kamil from UCSI Hospital, Malaysia. So this is one of my oral presentation for the Canabrava International Fellowship 2024. So my topic today is regarding the dysphotopsias, managing dysphotopsias from the cataract surgery. So, okay, this paper is from the Ophthalmic Pulse AAO, January 2023. So, for the introduction, dysphotopsias is the light-related visual disturbance experienced by pseudophakic patients in the peripheral vision. Okay, it's a common but yet understudied complication following cataract surgery. So it can be a leading cause of patient dissatisfaction despite otherwise successful surgery. So this paper is the goal is to review the types, causes, and management strategies for dysphotopsias. Actually, there are two main categories for the dysphotopsias: the positive and negative dysphotopsias. So for the positive dysphotopsias, because the symptoms is the bright streaks, rays, arcs, or flickers in the peripheral vision. So the mechanism is there is glare from the edge of the IOL, which reflects light into an unintended area of the retina, such as in this picture. The image is the ray is reflected towards other part of the retina, so causing the positive dysphotopsias. While in negative dysphotopsias, the patient will experiencing shadows at the temporal vision, where the like such as for the right eye, the symptoms may change with the gaze direction. In this picture, for the right eye, when gaze to the left, the symptoms will be much worse, and then gaze to the right, the symptoms will be improved. So actually, what happened actually, um, the mechanism because the light is passed unrefracted, hitting the side of the retina, so leading creating a gap in the illumination, such as in this illustration you can see there is a gap. So the patient will be experiencing negative dysphotopsias. So what to consider? So patients need to be discussed the possibility of dysphotopsias with before the surgery. And the IOL selection, rounded edge IOL is associated with fewer dysphotopsias but higher risk of PCO. However, for square edge IOL, if getting higher risk of positive dysphotopsias. However, the newer IOL with the frosted edges showed that the lower risk to get the dysphotopsias, such as in this picture by the Technis IOL, where the frosted haptic as well as edges of the optic um, leads to the reduced the dysphotopsias phenomenon. And also the selection of IOL material, the silicone oil, of course, with the lower refractive index, resulting in fewer PD. And anterior surface curvature is a more rounded anterior surface reduce the PD formation. So, what are the intraoperative considerations? Firstly, this IOL is at the ideal placement is the correct placement inside the back, where the anterior capsule overlap the optic edge. So in this position, some of the patient experiencing dysphotopsias. So limited studies suggest to put the IOL in the horizontal manner, such as in this picture, horizontal manner, to reduce the negative dysphotopsia. And other outer set, rexis size, overlap of capsular rexis and IOL, haptic orientation. There is limited evidence or no evidence on the incidence of the PD, positive dysphotopsias. So, post-operative consideration. So, when the patient complaining of the dysphotopsias are either positive or negative, so firstly, we need to rule out other issues, which is vitreoretinal traction, posterior capsular striae, such as in this picture, we can see the posterior capsular striae astigmatism. And we need to reassure the patients because usually these photopsias are benign, and there is a role of the neuroadaptation, and sometimes the neuroadaptation can be achieved either weeks to months and sometimes up to a year. So the patients need to know the role of neuroadaptation also. So otherwise, we need also to rule out the ocular surface issue need to be optimized, and also any residual refractive error also should be corrected in order for the patient to achieve the best vision. Some studies showed that the myotics such as pilocarpine have effect on the reduce this photopsias. However, there is limited evidence with this medication, and some side effects also for longer use. So for the persistent reserve persistent dysphotopsias, what to do. So we need end up to be in the surgical intervention. For the positive dysphotopsias, the surgical intervention is the IOL exchange back to back. Means that we exchange with the lower index of refraction, such as silicone IOL. And for the negative dysphotopsias, we can do either we try the secondary nasal reverse optic capture, such as in this picture. We prolapse the edge, the nasal edge of the optic anterior to the capsule. And then the second option is IOL exchange back to sulcus with reverse optic capture. And then the third one is we do the surgical truncation of the nasal edge of the IOL optics to reduce the negative dysphotopsia. Other reported technique is the laser anterior nasal capsulotomy, as well as piggyback or add-on secondary sulcus IOL. So for the patients complaining of dysphotopsias, we need to consider for delay for any YAG capsulotomy because of the possibilities of IOL exchange and further surgical intervention. So we need to timely do the YAG capsulotomy. Okay, as conclusion, we need to have a clear communication with the patient. There is possibility of dysphotopsias, although the surgery went well. And then the second one is we need to manage the residual refractive error, dry eye disease, and to need to rule out the retinal traction issues and also posterior capsular striae issues. And we need to emphasize on the role of the neuroadaptation. And the role of neuroadaptation may take up to a year, and need to delay the YAG capsulotomy until there is no symptoms of dysphotopsias, because maybe this patient needs later surgical intervention. And IOL exchange may be effective using a lower refractive index IOL for positive dysphotopsias. That's all for my part. Thank you.
Iqmal, congratulations. Amazing review about dysphotopsia. Most of my case that I receive solve with neuroadaptation. This is an important point to discuss, because when you receive the patient the first or the second week, you need to talk to the patient or wait for 1 month or 2 months, and because the most of this case will solve in quickly time. In your experience, the case that you had was like this, solved with neuroadaptation?
Yeah, actually, most of my cases, they are not complaining of dysphotopsias, and I never been encountered such cases, to be honest.
Good. Can you unshare your screen too? Your screen is shared.
All right.
Any question to Dr. Iqmal? Let me see if you have question in the fellowship room. Any question? Iqmal, I think you don't have a question. So let's go to share my screen. Agustin, Mohammed, any question to Dr. Iqmal?
No.
No? Agustin, if you want to answer your questions, no problem. You can answer while I share my screen, okay?
I already did it. Some answers.
Okay.
Well, the main question is what other options do we have instead of CT Lucia? I always use the AR40, the Sensor 3, because we don't have availability of CT Lucia. But the haptics of the PVDF are the best for Yamani, no doubt. problem itself is related with CT Lucia, no with the haptic material. So if you are a beginner, probably the best you can do is use the PVDF haptics, and then
Yes.
you
No,
can
you
use
can talk.
the other materials like the AR40. I less but are less forgiven to kinking and breaking the optics.
Yes, I have few cases too. This is one of the problems. That's why I developed the four flange technique, because this tilt, and I love Yaman technique. For example, 2 or 3 weeks ago, I did one. That's the IOL was in the vitreous, and you use the same IOL. The problem is only the IOL, not the technique. Sometimes you don't have the right IOL in the country. Is the problem. Can you see my screen?
No, yes.
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 Okay, let's go week 8 in the advanced cataract course, class of August. Subluxated lens. I received only 3 questions. Of course, by my friend Dr. Juan Luis Ancheta. And yes, Juan, in all case that I have subluxation IOL or pseudosfoliation or any problem that you use a CTR, I insert the capsular tensor ring before the fake emulsification. Okay, in my hands, in my numbers, it's improved, giving more stability. And because in the past, when I start with subluxated lens, after to remove the crystalline, sometimes the bag scams and cams vitreous. So all case I suggest to use CTR before. Okay. Number this about this question, I don't use this frequently. Okay, I don't have experience to insert CTR in a long axial length, and only when the patient there is any complication. Okay, and about the number 3, there are some articles on this subject. I think it can be a good paper to discuss in our course next week. But I personally don't use the CTR to try to avoid torque IOLs. Okay, so the fellow that you present next week, I think you can discuss this topic. About the case of the week, if you remember, I sent 2 cases last week. One of these cases was this OPD report that you could observe the cornea spherical aberration, negative cornea spherical aberration. So in this case, the best IOL is a spherical one, okay, or a neutral one, if you want to do. But the spherical one is the best one. And I saw in our group, everybody mark spherical one. So I'm really happy because all of you study, and it's really important to observe because it reduces the symptoms, the post-operative symptoms of spherical aberration symptoms. Okay. The case 2, I sent this hydrophilic IOL opacification, and the attention that I discussed in the group was about this anterior capsule fibrosis, okay, this contraction syndrome. And the question was, what you need to pay attention in the intraoperative. Okay, in this case, when you have a extensive anterior fibrosis like this one, you need to have in mind that the most of this case, the HEPKI will be with fibrosis too. And it will be really hard to remove it from the bag. Okay, so I can show you on a video. There is no a lot of fibrosis, but observe, I really try, I inject before this part of this video, I inject a lot of visco between the haptic and, but observe, really large fibrosis. So what you do in this kind of case, you have two options, or remove all the complex IOL and the bag, or you can try to cut. In this case, I tried to cut. Observe, was not an amazing maneuver, but because you can observe, produce a 9-degree disinsertion, but was the option that I had to try to remove, but was not possible. And you see, I go and cut it, and the haptic stay in the back. So the another size was the same. Here you can see a maneuver that I use a simple spatula, and observe, it's really important to inject visco between the IOL, okay, the IOL and the bag, okay? And so here you can use this simple spatula to avoid you and to help you in cut this haptic, okay? And so you can't this haptic will be inside the bag. Here, just to show how to cut, know the curse, I really like to, is important to hold the complex, the IOL, okay? If you don't hold it, the IOL can't rotate, and so you can rotate this IOL in the incision using a two forceps, okay? A micro forceps, a two, and another forceps is important to rotate it to remove from the eye, okay? If you have, of course, a good 23 gauge micro forceps that you can cut it inside the eye, will be better, okay? Here removing the IOL. So let me share it. So can you see me?
Yes.
Guys, any question? Agustin, Mohammed, or any of the fellows of the members of the course that stay? I like your move to cut the haptic, less trauma out of the bag, remove the road complex. Yes, Joseph, I prefer to try it too, okay? It's just to discuss, but when you can cut the haptic, and when you have a really small 23 gauge IOL cutter, scissor cutter to cut the haptic, you can open a new incision, it will be easier. In that case, I had only a Vanna scissor because I was in my public hospital and I was necessary to use a Vanna scissor. Another question? No? Agustin, thank you for your presentation. It was really a pleasure to have you with our fellowship program. I think, I'm sure that the fellows and the members of the course like it too. And Mohamed Iqmal, congratulations, good presentation today. And the Agustin, you can know Iqmal and Mohamed, your final words, and of course our speaker, guest speaker, Agustin, to close the session. Mohamed Iqmal.
Thank you very much, Dr. Sergio. Nice opportunity to meet Dr. Agustin. Nice talk, and thank you all.
Yeah, me too. Nice to meet you all.
Okay. Thank you, Sergio, for the invitation. Nice to meet your fellows. You are doing a great job with your course. I think it's a great opportunity to learn. I learned a lot of things with the talks. So I'm here when you want to count with me. Thank you.
Go prepare a case. December 4 will be the 2024 Cataract Day. It will be a pleasure if you send a case for us. Okay?
Okay, I will send you. Thank you.
See
Thank
you
you.
guys. Thank you.
Thank you.